We have done some difficult ones, but this was really, I think on a scale of 1 to 10, this was 11. Today we're going to be talking about one of the more difficult cases that my team and I have done in the recent few years. This was a patient who presented to us with visual loss in the left eye, and this is the skull base. So the tumor was actually growing inside the nose, in the cavities of the nose, growing into the left eye and compressing on the nerve of the left eye. It had also eroded through the anterior cranial fossa base, what we call the skull base, and part of the tumor had grown and was pressing against the brain. So today we're going to be having a brief conversation with the patient and the patient's family, who've kindly consented to allow themselves to be recorded. And then my colleague and I, Dr. Banu Prakash and I, are going to be discussing the nuances of this particular case, how difficult it was, what were the challenges that we were expecting, what we actually encountered, and how it all went. So I would like all of you to participate in this video to learn more about how neurosurgeons approach difficult cases. And this is really a story about the courage that the patient and the family had, determination that the surgical team had to see it through till the very end and make sure that it all ends successfully and satisfyingly for everyone involved.
We are basically from Dubai, and he had a visual problem in Dubai. While driving, he had a problem.
Mm-hmm.
He used to say, then we consulted the doctor over there, eye specialist. He told, might be cataract, you can go India and you can do since we didn't have insurance over there. So
left eye was the problem.
Left eye was the problem. So when we came on vacation here on 26th and 27th, we went to Agarwal Eye Clinic. Over there, they told us that they checked and we were forcing this is the cataract problem only. Then they checked and they told it is not cataract. You have to immediately consult the neurologist. We went to one of the neurologists. So they did the contrast and MRI, and then doctor told that he have this pony tumor, and they have to operate. They told they have to do the surgery through brain.
Through the skull. So they have to open the skull. So that is called a craniotomy. Yeah.
Yeah. So and also they told me so many plus and minus what might happen, and it was very scary. Then Sarvana told there's a Arvind Bhateja sir, so better we will meet him. So when first I spoke to you, it was so, the first meet only it was good, and you explained what is everything, and through the nose you are going to do the surgery. So it was so convincing. So we started our procedure in this hospital.
So then after you got admitted, what was the whole experience like?
First day is fine, but when I signed that consent, I was so very scared because I saw all thing.
Yeah,
it
when
was
you explained all the risks.
The complications and the possible risks, And also I told you that we may have to open the skull in case we are not able to achieve a proper result from the nose.
But
and then on the day of the surgery, because we were inside the OT and we were all battling the tumor.
It was,
but I'm sure you had some battles of your own to deal with.
That is really, that was one of scariest day of my life.
What was going through your mind?
I don't know. I've been crying all day, I can say.
But you were getting regular updates.
Yeah. Dr. Kiran, he used to come, and it was whenever he come, he was so positive, I gained that, positive energy. Whenever 3 times he came, on 3 times also, it was so positive, and it was...
Then after the surgery, when you saw him in the ICU, what did you feel?
I don't know, I have so much mixed reaction. Everything went well, and it was, skull was not open, that is also, it was this.
But then were you kind of relieved that he was okay and he was able to talk and recognize?
After the surgery, when you came and told that everything was removed, initially when we discussed, first you had told only near the eyes, you are going to free that this tumor near the eye nerves. Then when you told that everything was removed, it was really
No, our plan was to remove the whole thing, but the most important part was what was compressing on the
Yeah.
nerves. Yeah.
uh, that was very relieving, and really it is, I can say, it's second life.
No, it's much different, but not in one time. It will take time. I know that. This doctor told me also it will take time. Really, I am happy. And I know that, especially when doctor telling them, I went home and I told also. Nobody means Dr. Bhateja I told all the Mangalore also, they told me, but I told no, if you are doing anything, only in spas, Dr. Bhateja said.
We met at least one, two, three, four doctors we met to this. He was convinced only.
Did you have much pain after your surgery?
No, not that much.
No pain.
No pain.
Maybe due to surgery, I think he has become much weaker.
Yeah, that's because the surgery was a very major operation and it took nearly 11 hours. And then the recovery process also, we had to keep him under close observation for about 4 days in the ICU. And then a lot of medications, antibiotics, and so many things have happened. So that's naturally a stress on the body. Now the body is trying to recover from that stress.
Yeah, it is.
So that will happen over a period of time. But I think overall he's done very well.
Do you feel you have a change in voice after surgery?
Yeah, that nose block very well.
Aditi just saw him. He's got a lot of crusting. So that's why it's like a nasal twang. So it's been 12 days now since the surgery was done. And his recovery is going well. The good news is that we haven't had any complications so far from the surgery.
After this one, it was so easy. When he's recovering.
Nobody believed him. He was doing friends that was there telling them. Then where did the operation and they are asking.
You can show them the videos.
Say, go for a surgery only. Don't wait. Don't waste your time.
I'm here with Dr. Banu Prakash, who's a co-surgeon on our team. He's a neurosurgeon and we've been working together for the last 16 years. Yeah. So this was a very difficult case and we needed to have a team approaching this case because it is really difficult for a single surgeon to manage this. So we had Dr. Banu, Dr. Chirag and myself who are involved in the surgical care of this case. And this was the MRI. This is called the coronal section. So this was taken from the front. So actually if you scroll forward, you can see the two eyeballs. This is the center part here is the nose. And as we scroll backwards, you can begin to see this blackish tumor appearing in between the two eyes. So this is called the ethmoid sinus. So this is the sinuses in the nose. The tumor was growing within that and it was growing in such a way that it was growing into the nerve of the left eye, also the right eye, but more so the left eye. And it was growing up into the cranial cavity. So this was actually pressing on the brain. And this looked like it was a very hard, bony tumor. So when Dr. Banu and I discussed it, we were thinking of various options. One was to try and approach this tumor through the nose using what is called endonasal endoscopic skull-based surgery. The other option was to go through the skull above, which is a craniotomy. What did you think about doing a craniotomy versus doing an endonasal approach?
That's what, when I saw the images, I felt maybe we might be able to take it out predominantly from the endonasal route, but we might not be able to separate it from above near the optic nerve and all. But one good thing was the CSF planes were very much defined on top of the tumor. So that arachnoid cap and these things, that made me feel maybe if we are lucky we can get everything from the nose itself. But in between also while doing surgery, it was very laborious and there were times when we thought that we'll end the endonasal and then go for the cranial. But definitely, ultimately, patience pays paid, and then we could get the whole thing.
My belief was that because there was such a large component of the tumor inside the nose, going through the nose primarily would have been the best option, because that was the best way of removing as much of the tumor as possible with the least amount of morbidity to the patient.
Yes, because even if we do a transcranial procedure, we won't get the whole tumor out. So we had to do an endonasal also. So as well, try endonasal first, and then if you can get everything through that, then that would be the best way.
So the interesting thing is, of course, this is the coronal images. There are other images as well showing the tumor, and fortunately, the tumor wasn't really pressing on any major arteries. It was not involving the pituitary gland. It was only in the sinuses and around the nerves of the eye. Then, when the patient came for admission, we decided to do a CT scan, and the CT scan will load now. To our absolute horror, we found on CT scan that the tumor was completely made of bone, hard bone. We were hoping that at least some part of the tumor would be non-bone, somewhat soft. But the CT scan was a real shocker. And when we saw the CT scan, we realized that we have a very difficult task on our hands.
One good thing in the CT scan was there were some clefts of corridors within the tumor, which made it slightly okay. Maybe that is the way we have to go between the bony lobules.
So this is a cross-sectional image of the patient's head. So the two eyes, the right eye and the left eye, this is the nose and this is the sinuses. So you can begin to start seeing this whitish tumor here on the right side, very large on the left side. This is the bone of the eye which has got involved with the tumor. And as I scroll up, you can see that entire bony tumor there, which is growing up into the skull base, compressing on the left eye very badly, left eye optic nerve very severely. So you can see this in different 3D orientations. This is the coronal orientation. So you can see the tumor here growing all the way in between the two eyes and growing up into the skull. And you can see it's all whitish. So anything white like this on a CT scan means that it is hard bone. Another view, the sagittal view. So this is looking from the side. So you can see that large tumor here growing from the sinuses all the way growing up into the cranial vault. So you want to tell us what we encountered when we actually went in. So the initial part was that we had to make space in the nose for us to put in the endoscope and then to start dissecting the tumor.
Yeah, his septum was also deviated. Thankfully, his nostrils were large, so now we could accommodate 2-3 instruments in the nose. But the septum was deviated to such an extent that we couldn't get the flaps, what we call the adult flaps, to cover later. And it got torn, so we were like very skeptical whether we will be able to get a good repair. But still, we took the flaps on both the sides, and then when we entered the tumor, it was like hard, rock hard, and drilling. It was like, hours went on within like, and definitely it was too exhausting. At one point, we felt maybe we might not reach the end, so we might have to go from above. We were about to get ready, and then we felt okay, let's give a last try, and then that last try actually we entered into that cleft, the one space wherein some soft tissue was there within the bone, and when we could try to move the whole thing started moving. That was the break point for us. I think then we felt okay, maybe we have a chance, and we kept on drilling, and definitely I sort of when we cut the tumor into sort of bits and pieces, that's when we started delivering it. So that's what
I think what also made a difference was that during surgery we used neuronavigation.
Yeah.
That made a lot of difference because it gave us confidence about where we were drilling, how much tumor was left, where we needed to drill, because it guided our work in a more precise manner so that we saved on energy and time. And in spite of that, it took us almost 11 hours to complete the surgery.
Neuronavigation helps us to know where we are and what, how much more to do and what exactly. Sometimes because inside the tumor it's too confusing which direction we have to go, how much depth is there, and especially the optic nerves which was being compressed, we had to be precisely over it and then decompress it. So definitely navigation helped a lot, and then the drill and even the repair mechanism itself is a new generation repair which has created such a wonderful seal that no CSF has leaked. So ultimately it was all probably good time of the patient also, I think.
Yeah. And I think I just want to re-emphasize the nasoseptal flaps because that is something that has absolutely changed endoscopic skull-base surgery. Without those flaps, the complication rates in endoscopic skull-base surgery were extremely high, and a lot of patients ended up with very severe CSF leaks, that is leakage of the brain fluid through the nose, which could not be controlled and ended up succumbing to those CSF leaks. But the nasoseptal flap has become the workhorse of endoscopic skull-base surgery. So essentially what a nasoseptal flap is that it's a flap which is raised from the nasal mucosa, which has its own blood supply. So in medical terms, it's called a vascularized pedicled flap. So the pedicle means where it's attached. One side of the flap is free, other side is attached because the blood supply to the flap is coming through that pedicle. And these flaps are extremely effective at sealing the defects in the membrane that surround the brain. Now in this case, there was a huge hole in the membrane that was covering the base of the brain, called the dura mater. And if we had left that hole as it is, it would have led to a catastrophic CSF leak, which would have killed the patient. And thanks to the understanding of how to deal with these defects, thanks to the advancements all over the world, we did a multi-layered reconstruction. So what's been shown to be really beneficial in such large defects is not to use only one layer of reconstruction, but to use multiple layers. So we took fascia from the thigh, we used artificial dura called redura, and on top of that we put the nasoseptal flaps from two sides because it was a large defect, so it needed more coverage. And that reconstruction itself took almost 90 minutes of our time during surgery. And it was the fact that we paid close attention to the reconstruction that I think largely contributed to the success of the surgery. And I think
even the nasal spur had split the flap on the right side into two.
Yeah.
So we retained both the strips of tissue which was slightly attached anteriorly. Maybe every small bit and detail has helped in a better way. So preserving whatever is natural and whatever is helps in healing much more faster.
So I think the big takeaways are that we were able to avoid a craniotomy. We had to split the tumor into multiple smaller manageable chunks. So this is a life lesson actually. If you have a task that seems too big, break it up into smaller portions and that becomes much easier to deal with. And the same thing applies in big tumors in neurosurgery. So, divide it into easier, manageable bits. That will make things happen, hopefully in a very successful way. Memorable case.
Definitely. One of the most difficult cases till now, and probably maybe I don't want to do it again.
But very satisfying case because it was challenging and we were able to get a good result. So it was a very satisfying case for the whole team. And I think everybody worked very hard to make it happen. We want to show you the post-op scan also. Before the patient got discharged, we did a CT scan. So that is the post-op CT scan. So you can see wherever the white areas of tumor were are all gone. And there's no tumor left anymore. So even the optic nerve which was compressed has been decompressed. Now you can see the optic nerve, optic canal very clearly. A wonderful result from the surgery. Kudos to everyone involved. Excellent work.
Good teamwork.
So I hope you enjoyed our interaction with the patient's family and with the two neurosurgeons discussing the case. This was certainly one of the most difficult cases we have done. And What we learned is approaching difficult cases with expectations of the possible complications, being prepared for those eventualities well before we actually perform the surgery, paying attention to certain nuances like multi-layered CSF dural repair, using certain enabling technologies like neuronavigation, 4K endoscopy, all make a huge difference to the outcome of the case, to the fatigue and the motivation of the surgical team, the operating staff, and everyone involved. One important message that needs to go out to everyone who is watching this video, and whoever is not watching it, please share it with them. The fear of surgery should not allow you to succumb to your disease. More often than not, we as surgeons would not advise surgery to anyone if the complications of surgery are extremely high. And the rule that we always follow is if the risk of surgery is higher than the natural history of the disease, then we do not offer surgery to such patients. We also would like all our patients to have successful outcomes from surgery, and definitely in the best interest of the patient, we would only advise surgery when we know that the complications are not so serious and are manageable. I would like to thank every single member of our team, right from my secretary to all the doctors, the junior doctors who were involved in the care of the patient, the intensive care staff, the OT staff, the surgical team, the neuroanesthesia team. Every single human being involved in the case played a pivotal role in making sure that the outcome of surgery was excellent. For more such content, please like, share, and subscribe.